Hey, John, election day is coming. Can I get the COVID vaccine before I head to the polls?
Sorry, no. You, my friend, may be the last in line.
So, John, a vaccine's going to be approved, one of these days soon. And once it is, how fast do you think COVID will be vanquished?
Come on. I mean, we all know that this vaccine thing is being oversold because we're in an election year. We need a vaccine, but it's not really going to come fast. And as you know, vaccines are really complicated. I mean, when people think vaccine, they think instant solution. Measles vaccine, 97% effective. Polio, 99% effective. We're talking about a coronavirus. The coronavirus presents in the same way that the flu coronavirus does. And the flu vaccines are only like 40 to 50% effective. So even when the vaccine comes, we've got to be really careful that not everybody has the delusional expectations that you have, that there's going to be an instant solution and it's going to show up quickly like a miracle.
Well, John, I think you're right about that. There's some other things besides the effectiveness. There's also distribution, which we talked about on the podcast. It's also a question of just how long does the protection last, assuming that it works, and then what else is happening at the same time. So I think you're right. And these
Well,
trials.
but wait a second. What do you mean by how long it lasts? I'm assuming that if it works, right?
Listen, that would be a nice simple solution, but you get the flu vaccine every year. You need booster shots for some of these vaccines, and it's just sort of unknown how long it's going to last. So you can't just assume that you're safe to walk around forever. And that's one of the reasons why these vaccine trials have to continue. It's not enough just to have the vaccine approved, because the first approvals are just showing, when some dozens of people in the control group get COVID and people in the other taking the vaccine didn't. You need a lot more data to see how it works.
Well, there's no question that we are in the biggest, largest social medical experiment that the world's ever seen, with more science moving faster than certainly I think we could imagine, leveraging computers and machine learning and AI and research being shared across border, 300 plus candidates for vaccines. But I think the thing that people have to realize is that vaccines are not always a miracle cure, and the miracle cure doesn't always happen. We've been looking to do an HIV vaccine for nearly 20 years and have made very little progress.
John, there's some things that I'd love to see, studied in the vaccine trials. I'll just throw them out there in case people are listening who might be designing those. So one is some specific populations, older people, younger people, sicker people, men versus women. We want to know how long the protection lasts. We also want to know, like with the flu vaccine, a lot of times it might not prevent you from getting the flu, but it might make it less severe. And there's also a question, since we know COVID is so transmissible and so infectious, whether it means that once you have the vaccine, are you going to still transmit it to others or not? And there's going to be a bunch of vaccines, so we need to know, once there's, God willing, a choice, how to compare one with another.
Well, I think your point about data is really critical, because the reality is that we do have different kinds of drugs, and vaccines can affect different subpopulations differently. And I think there will be clearly an enormous amount of pressure to get this out and try to create what's effectively herd immunity. But, herd immunity isn't really going to be realistically achieved until you're well over 60 or 70% based on the current estimates of people taking the vaccine. And we're currently seeing a situation where, almost a quarter of people don't want to take the vaccine. I mean, what kind of environment are we creating, or kind of solution do you think we're going to see, David, if you've got a vaccine out there of uncertain duration and only a third of the people, or say 30 to 50% of people who could take it, do actually get vaccinated?
I'm going to treat that as a rhetorical question, John, because I think the answer is we're not going to have that much protection, if that happens. I think you realize that. There is work being done now in terms of, who gets a shot when. And I asked before, am I going to get it on my way to the polling place? And no, I'm not. But, there's some principles that are being put out there. There's a 4-phase approach that's being talked about. What's your view about, like, when am I going to get my shot? When are you going to get your shot?
Well, I would imagine that we would be pretty far down. I think you clearly once we have a vaccine that we think works, I think the first group to get that vaccine or to be protected, the priority groups have to be the frontline doctors and caregivers, the paramedics, the caregivers in nursing homes that are exposed. I've got to think that the people who take care of us have to be the first people who we take care of. And then I think you got to look at folks who are at high risk factors, like the folks who are the current targets, folks who are with diabetes or folks who are older with multiple chronic conditions. And I think that anyone who's at we have this weird thing with the coronavirus where a number of people get it, but some of them are super spreaders. If we could make sure those super spreaders are eliminated from places where or from food distribution or hospitals care, where they're touching a lot of vulnerable patients, or they're just touching a lot of people and situations, I think that those would be the priority: the caregivers and the patients or the potential patients who are most at risk. How would you prioritize it?
Well, John, I think we're seeing that great minds work alike, at least John Driscoll and the National Academies of Sciences and the CDC, because they're developing something similar, and they have some principles about how they do it, about different risks of acquiring an infection and risk of serious illness and death and negative social impact. So they've got a 4-phase approach. It's like what you described. You get the health risk, the high risk healthcare workers and the first responders, or those with comorbid conditions. But then they move to the second phase is people like K-12 teachers and staff and essential workers. They get to young adults and kids, and then everyone, which I guess is going to be us. And they talk explicitly about equity being a cross-cutting consideration. And they actually talk about systemic racism and the disproportionate impact on people of color. So I think a lot about how this is implemented actually depends on who's in the White House. If it's Biden, then I think they're more likely to follow the principles and the guidelines. If it's Trump, it's kind of a weird situation, because on the one hand, I think they'll sort of the powerful will grab up the vaccine first on the one hand, but on the other hand, you've got a lot of vaccine skeptics too. So I don't know how it will play out.
Well, I think the strangest thing is that Trump has both put more money towards vaccines than any other president or government in U.S. history. At the same time, he cultivates, supports, and spreads a lot of the anti-vax movements. Sort of what they call their truths, which I think are a bunch of lies. He's very much taken a position to tolerate, if not support, anti-vaxxers, and it's sort of a peculiar position to be committing, tens of billions of dollars to the supply chain, to manufacturing, to research, and then to sort of suggest or support skeptics. I do think you're making a really important political point, that if we want to support science and we want government to work and care to be equitable, there's just not a question. You gotta be a supporter of Joe Biden, and I think it's going to be quite confusing if the Trump administration, while tolerating the anti-vax movement, is also trying to distribute vaccines. I don't see how that is going to work too well. So I don't think we've seen the last of masks and social distancing.
Well, John, I think the anti-vaxxers and the anti-maskers will have to be out together for Halloween, if not sooner. And that the fact is, we still will need to wear masks and do social distancing, even with the vaccine in place. I got a couple of other topics before we round things out, and one is about schools. I thought that we would probably prioritize schools, but I want to know what you think about how the vaccine availability is going to affect schools. And then I want to talk about nursing homes after that.
Yeah, I think with regard to schools, because in general, you've got a lot of very young people who tend to be taught by very old people. Some of the best examples recently of solving the school opening problem are schools like the ones being supported by the Broad up near you in Boston, where they are testing constantly and they're doing contact tracing and they're quarantining with some discipline. You have testing and tracing in place, particularly with the population, kids who, although they might get infected, are unlikely to get really sick. If you're testing people 3 times a week and really doing rigorous contact tracing and required quarantining, I think you could open up the schools and we could wait on the vaccine and not worry about that. I think what we need to be focusing on is the vaccines, which we should honestly be focusing on testing and tracing capacity across the country. But the one place where it's shown it's absolutely working are schools like the University of Illinois Champaign-Urbana, which is a large public school. The Colby, the Bates, the MITs, and closer to where you are, Delaware State. I mean, where you've got a whole range of historically Black colleges or big public colleges or small private colleges, where you've got that testing and tracing in place. It's a model for how to reopen society, and you can kind of put the vaccines aside. It's effectively why Germany is open and we are not, because they've got testing and tracing in place. The one place I still worry are nursing homes and elderly folks with comorbid conditions. I think they're going to be vulnerable for a while. What do you think?
John, on the school side, I think you're right at the kind of post-secondary, at the college level. For the younger kids, K through 12, it's more of a challenge because the vaccines are out there. They're not really being tested on kids. So that means that you wouldn't really want to require someone to get the vaccine, to go to school. And especially, if you compare that with something like measles or mumps or rubella, which are childhood illnesses, where you have vaccines tested on kids and that it affects kids, then you're going to see that. Now, flu shots you don't normally require, but this year places like Massachusetts are requiring it. So I think the main impact that having the vaccine is going to have on the schools for K through 12 is that the staff and the teachers are going to be able to be vaccinated. So I think that's there. Now, nursing homes, John, you and I aren't huge promoters of nursing homes kind of in general. So we think that people can be in their own homes whenever possible. Vaccine, I'll point out, also really hasn't been tested on nursing home populations either. I do think that if the distribution follows the principles that we talked about with the CDC and the National Academy of Sciences, that actually should help because the workers there who have been a big vector of bringing the disease around, they're going to be vaccinated. So that's kind of how I see getting out of it.
But I do think, David, we're missing the whole point here about the opportunity with testing and tracing. We're betting hundreds of billions of dollars globally on a vaccine that may or may not work, when with tens of billions, we could set up testing and tracing and open up society right now. I think while we're focused on the vaccine and gosh, it's exciting, and the notion that, we are currently at an administration that is either hoping for miracles or believes in miracles. I'm not quite sure which depending on the day. We should be building on what works right now and investing on what could work tomorrow, as opposed to assuming that tomorrow is going to come closer to today. Because I do think that the vaccine is a high risk, complicated solution to a very dangerous COVID that is broken our economy and is hurting and is infecting and making too many people sick. We don't have to be here.
John, I would agree. And I think we're going to have to use everything at our disposal: the social distancing, the mask wearing, vaccines, testing. And as I saw somebody say the other day, we may have fatigue about the virus, but the virus doesn't have fatigue about us. It can go on indefinitely.
On that happy note.
Yeah. Well, let's wrap it up, John. Yeah, I can't imagine where the next questions are going to go. So that's it for another edition of Care Talk. I'm David Williams, president of Health Business Group.
And I'm John Driscoll, the CEO of CareCentrix. Thanks for listening.